Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
So during my residency, the most important phrase that I have learned is that if you don't know where you're going, you can never get lost. That summarizes the nature of our profession. That we always have to clear image of the end of the treatment. So we have to keep end result in mind when we even start the case. So there are more than 36 million Americans do not have any teeth, and 120 million people in the US are missing at least one tooth. These numbers are expected to grow in next 2 decades, and then tooth loss happens from decay and gum disease, and as a result, injury, cancer, or simply wear. Right? And when we see this type of edentulous, we don't worry about because we know that the baby teeth will be replaced by permanent teeth. But when we see this type of the edentulous space, we start to worry about because we know that the lateral incisor will never grow back. Okay. And then in the geriatric population, the ratio of edentulous individuals is 2 to 1. And about 23 millions are completely edentulous, and about 12 millions are edentulous in one arch. Okay, so whenever they're edentulous, they suffer from like a lack of mastication and lack of aesthetics, compromised aesthetics, and a social status. I mean, like psychosocial behaviors, right? And then when we, as a prosthodontist, whenever there is an edentulous space, we have a removable prosthesis. We have a fixed partial dentures, right? And then we can also use implant, thanks to the inventor of modern dental implants, Dr. Brandmark. So from dental school, whatever we do, we always start from diagnostic workup. So when there is a one tooth missing, we do the tooth setup there. Like it could be wax up, it could be the denture teeth, it could be just tapered teeth. And this particular case was the tapered teeth exercise, right? And then here for the complete edentulous arches, we always start with a wax rim, and then we do wax rim try-in, and then that wax rim will be replaced into the teeth setup, and eventually that could become a permanent prosthesis. Well, we hope it's a permanent prosthesis, but we know that everything that we make, sooner or later, it will fail. So this is a big picture that we always have to design where the teeth has to be from the beginning. And then when there is only a single tooth missing, The parameter is fairly easy to assess, right? The space is bounded by adjacent teeth and opposing teeth, and there will be contralateral serve as references, right? So you have seen so many beautiful cases already. So, and I'm certain that you have clear idea about workflow of implant restorations, right? So it doesn't matter if it's analog or digital, the single implant crown restoration should be relatively easy for primary assessment, okay? But however, even though we love to say sky is the limit, for our profession, it's not. For complete edentures patients, the oral cavity is our limit. And then for the single missing edental spaces, actually just adjacent teeth and opposing teeth is the limit. So our goal is to give a patient a tooth, right? So for this case, number 8 is a restored tooth, and from there, right? So in order to have the tooth in place, we have to have something to hold onto the tooth, and that in implant dentistry, that is called something called abutment. Right? And abutment has to connect it to the implant, and implant is connected to the bone and soft tissue. Right, and then as opposed to fixed partial denture, the prosthesis is held by adjacent teeth. Right? So the advantage of the implant was that no adjacent teeth will be compromised. Okay, so for this case, this was a combination of tooth-borne crowns and one implant, because this girl has been involved in the accident, and then all front teeth were either broken or knocked out. Right. So here we always start. This is an example of a final wax up. So we can kind of see that the wax pattern follows the exact emergence profile, or CEJ we call it, right? And then from there, we take this thing out and then measure from this point to the implant platform vertically and horizontally, and then connect those. That will be the final contour, right? So that's a very conventional way to do it. And of course, nowadays the digital dentistry makes it a lot more easier. Okay, so when we do this, we have to make sure that all the line angles, transversal line angles, and height of contour, and all these subcritical, the contour development has to be idealized. And then this is going to be this is actually the final provisional, and because you can still see the preparation and the zinc oxide usinal temporary cement in there. Okay, and then this became the definitive prosthesis. Okay, so apparently I don't have the definitive prosthesis on the slide. So this is a good example of soft tissue management. So sometimes you do get patients showed up in your practice with existing implant. Right. So this is how patient presented to my clinic, and then first thing you can see is the soft tissue is especially number 9 is under contoured, underdeveloped, right? So the day of the first day of appointment, you take this out, modify with acrylic, and then the modification method is the same as the wax pattern. So you just add to the contour that you wanted, and then take it out and then connect to the platform, right? And then this is the modified, the provisional, and then we can duplicate that into the custom impression coping. And then using the custom impression coping, you get the contoured soft tissue information. And then from there, you can come up with a definitive final wax up. And then when we do final wax up, you really want to make sure it is the facial contour and everything, lingual contour, incisor edge, and has to be almost identical or symmetrical to contralateral. All right, and then this is the final provisional. And you can kind of see the incisor edge, the translucency was a little higher, the number 8. And then the reason for that was because of the crowding, slightly crowded mandibular anterior. So number 24, 23 were a little bit more facial than 25 and 26. Right? So that's why when we adjust this and recontour the crown to work with the mandibular anteriors, so we lose more structure here. Okay, maybe that was why initially when patient had an accident, this tooth was knocked out instead of number 8. Okay, so in the beginning I didn't notice the very slight crowding at the mandibular anterior, and then this is the end result of that. Okay, but the definitive wouldn't show. I'm sorry. So definitive wouldn't show that much of translucency here. Okay, so this is a definitive. All right, so we have seen proper implant positions and depth, and then that was one is the final wax up, and then one was the when patient showed up with the existing provisional and how you deal with the provisional. So the principle is the same. You develop the definitive contour first, and then connect all the contour line or finish line into the platform to develop the subcritical contour. Right? So this case is very different. So a very beautiful lady, young lady, and then this is the definitive crown on number 10. You can actually tell very slight different in soft tissue colors and texture here, right? And then the shade is slightly off as well. And also this patient was involved in accident. So everybody will say, oh yeah, this is a good result, right? Acceptable result. And in this case was started from here. And then this is the definitive wax up. And then when we remove the definitive wax up, the final wax up, you can kind of see the implant platform here already. And we always talk about implant has to be like 3 millimeter from the, like proposed the CJ, the down, and 2 millimeter, right? So there are 3A to B principles, and initially the 3A to B principle was not developed for the aesthetics, but it was for the biological responses, and you want to have a thick soft tissue, and then you want to have thick buccal plate to make sure implants are stable in the long term. But nowadays, later on, we use that for the subcritical contour development as well. So back to this case, the implant was placed very shallow. Okay, so for whatever reason, right? And then you can kind of see that this implant is Ostrow implant, and then this is the definitive the CEJ we want to get, right? And then because of the design of the implant and implant abutment connections, we cannot create any emergent profile there. So this crown is going to be a saddle design on top of the soft tissue. And we know that with that type of design, patient will have the challenging time to keep it clean. But what can we do, right? And then, but another aspect that makes us a little relieved was that since patient was very young, and we know that other teeth will grow, right? And that implant doesn't move. So hopefully in 20 or 30 years later, this implant will be in the correct position by eruption of the other teeth. Okay, so that was too shallow. What happens if the implants were placed too deep? Right? So this is the same thing, like we do the final wax up for 2 units, and then we take it out, and then this is particular case was based on 3i implants, biomed 3i, and from implant platform to this CJ was 6 millimeter. Okay, and then the depth of this implant placement, there was a good reason behind it. The patient lost a lot of bone due to periodontal disease, and then the bone grafting wasn't actually really successful developing or augmenting the vertically. Okay, so that's why we ended up this case, and then you can kind of see how deep the cuff is, soft tissue cuff is. But this gave me perfect opportunity to work with the soft tissue recontouring, subclinical contouring. So deeper is fine. Shallower, you get more challenges, and you and patient get more challenges as well. I just said a deeper is fine, but it's not really fine, but it's a little better than shallower implant placement, because when you place implants very deep, there will be a huge discrepancy between adjacent teeth, and there will be big steps. So for the long term, the maintenance will be very challenging, and it might affect the adjacent teeth in the long run. All right. So we talked about correct placement, too shallow, too deep. What if implants are placed in the wrong angulation? Right. So this patient showed up with number 10, number 7 fractured. So it wasn't restorable. So our collaborating surgeon removed the tooth and then placed the implant immediately. Okay, and then this is when patient came back for the final impression, and you can kind of see that with the impression pin here, impression coping pin, you can kind of see the access channel will be right at the incisal edge. Right. So what do? Okay, this was one of my the early cases during my residency, and back then I've learned using the angle correcting abutment to change the screw channel, because we want to get the screw retained prosthesis for as much as possible. So we wanted to use the angle correcting abutments to change the screw channel orientation, and it was very successful, right? However, because of the very limited space here, right? So after you put the angle correcting abutment and UCLA abutment, which is gold abutment on top, and then put this the prosthetic screw in there, it was already hyperocclusion, right? Because put aside that you need 1 millimeter for the Teflon tape or cotton pallet to protect the screw head, and then another 1 or 2 millimeter for composite seal, right? So we don't have that space here, and you can kind of see that this is already touching, and then there's a space and space at the anterior. Okay. So for this case, we run into the problem with like how to deal with the implants are placed in the wrong angle. And back then, the angle correcting or angle screw channel wasn't popular. But we had angle correcting abutments that we have tried, and then whatever remaining is like a customer abutment. And then for the customer abutment, you also have the manufacturer providing already milled abutments, or you can customize your own custom abutment. Okay, so there are all difference between angle correcting abutments. You can change the angle from 15, 17, 30, all the way up to 45 degree. And I believe the 45 degree was used for the zygomatic implants previously, right? And angle screw channel, you can go up to about like 20 degree, depending on the manufacturer and implant companies. And in custom abutments, you can basically change all the angles. And then retrievability is very challenging with the custom abutment and cemented crown, because of you lose the information about where is the screw channel. So usually you have to destruct the crown to retrieve the screw, loosen the screw or broken screw, right? So these things I hope everybody think about before getting into the surgery, and then when you decide restore like different type of implants, especially when patients show up with implants already. And that's the partial reason that our profession moved on to placing some of our own implants, simple cases, and then slowly growing into the bigger cases as well. All right, so in this case, in order to make the custom abutment, you still have to make sure the definitive contour is controlled, right? So this is the definitive final wax up, as if it's just a straight abutment. Okay, so same thing, take it out, connect to the platform, and then make it to provisional, and deliver this provisional into patient mouth. And in the provisional, you can clearly see this with the non-altered screw channel. You can kind of see the screw is coming out right from the inside ledge, right? And this is not really good for the definitive prosthesis, especially when you use the porcelain here. It doesn't really matter if it's a gold crown, right? Because we do have some cases that the patient requests gold crown on top of implant at front. And then we cut back as if you're prepping the teeth. Okay, and then cast into the gold, and then put it in the deliver onto the implant. And on top of that, I used gold colored the PFM metal, and then this is the definitive prosthesis. So I had to do cement retain crown for this case because there was no angle screw channel options back then, and then there was not enough space for using the angle correcting abutments. Okay, but nowadays you have angle screw channel, and then angle correcting abutments, cement retain, and then manufactured custom abutments. But whenever you want to decide what type of parts, prosthetic parts you want to use, you want to look at the design, and then you want to look at what result you want to get. Okay. So these are different implants, right? And so this is the 3i implants, and you can kind of see the implant platform is right here, and then the gold abutment is right there. So and then when you develop the subcritical contour, you can connect from the end CEJ that you proposed to directly to the implant platform. And this is a Nobel replace the old one, but because of the flat surface here, and this is a platform, and you can still connect it to that. Okay, so basically it means that you can utilize the entire space, vertical space that you gain from the implant placement. Okay, so you lose very minimal. This is less than 0.3 millimeter. Okay, this is a Straumann implant, and a Straumann implant you can kind of see that here. Some part you can see the sandblasted portion, and then the polished portion, right? And implant platform is right up here. Okay, and then if you have looked at the Straumann implants, it has the platform platform switching concept, and the platform switching concept is good for the retaining the bone height and bone level, but you lose a little bit of space restoratively, right? So in order to compensate that, you might want to place the strong implant slightly deeper, okay? And this is another example of the Straumann tissue that after we received the definitive crown, we had to add the composite to create the ideal contour of the crown portion. And after that, we remove it and see, oh, okay, so now the tissue shape is like this, right? So now we have to connect this dot to the platform, right? And then by doing that, we are actually creating a lot of unsupported porcelain here. Okay, so the porcelain becomes too thick over there, so it has very complex the, the stress distributions. Right, so this is Astra implant, right, and you can kind of still see a little bit of the platform switching concept, and then, but this one, because the implant was placed too shallow, so you can't really see much. Okay, so these are all like how you develop the subclavicle contour, facial lingoli, right? And a lot of times we don't really pay too much attention to mesiodistal orientation of the implants, okay? And so this is the example of Straumann implant. You can kind of see a little flute here, so from the implant platform, and then this is about 1 millimeter or a little over 1 millimeter, and that you can only start start contouring from this point and up, this point and up, right? So that requires a little additional space for developing proper contour if you are working with a relatively larger crown size. Okay, and this is the 3i implant, and then at the molar, right? So you feel this is deep enough, but when you see the buccolingoli, you might see the different story. Okay, so now let's go back to mesiodistal the contact, right? So when you deal with the posterior implant crowns, it's the same thing. So you might just make impression and send it to the lab, and this is what's happening in the lab in conventional way, right? If you're doing PFM crowns on top of implant instead of zirconia abutments or zirconia crowns and with the titanium abutments, okay? So you develop definitive contour. So this is a buccal view, this is a buccal contour, and this is a lingual contour, right? And then take it out. After taking it out, you can kind of see anything that was not filled was covered with the soft tissue, okay? And then we have to develop the subclavicle contour to push away the soft tissue to create natural appearance, right? And then this article really talked about the size of the implants and depth of the implants. So basically, if your implants are narrower, you have to place deeper, right? And then you can kind of develop the emergence profile based on that. Okay, and then the diameter of the implants is always dictated by the width of the bone. All right, so now what is going to happen if implants were placed mesiodistally, not following the path of insertion? Okay, so this is the contact or path of insertion that you want. Okay, so the path of insertion is supposed to be like this orientation. Okay, so that was the contact. That is the path of insertion that we want, right? But you can kind of see here that implant was actually placed slightly off, slightly mesially tilted. So when you really deliver this crown, what's going to happen is that because the crown is sitting a little bit more, like when you do the final torque, okay, depending on the implant system, right? When you do the final torque, some crowns will sit a little bit more apically and distally. Okay, so let's say you have adjusted the contact perfectly from the beginning. After you final torque it, you'll find the distal is too tight and mesial is a little open contact. Okay, so there are a couple of things that you can do, right? So one is using the cement retained crown, which a lot of people do nowadays because it's a lot easier. It's the same as treating the natural dentition, right? So one is before you make a final impression for the implant, you put the impression coping or impression pin in there, and then analyze what is the path of insertion for the implant, and then alter the adjacent teeth contour mesial distal contact area so that it comply with the path of insertion of the implant. Okay, so after doing that, you'll be fine. You have no problem with this interproximal contacts. And then sometimes you get a space a little larger or a little smaller, right? So for this one, you can kind of see the premolars are missing, but it is a little too narrow for two premolars, but it's a little larger for the one premolar, right? So that's why we have made it to deciduous molar, like a baby tooth molar, which is supposed to be the replace for permanent premolar, right? And then the same thing to follow the contour of the buccal contour, palatal contour, right? And then this is the final wax up. This is what we get from the lab, exact duplicate. Okay? And the crown was delivered, and patient was happy. Okay, so that was some screw retained crown. And now this is interesting case that mixed implants. Two are old Astra implants, and one is a Zimmer implant. And we wanted to do remake the prosthesis because there was some problem with the old prosthesis. Okay, and from the closer view, you can kind of see that one implant path of insertion was different, right? And then it is actually coming out from the upper surface of the definitive prosthesis. So we wanted to use the angle corrected abutment, right? And then this is angle corrected. And then for now, the screw channels you see is very parallel to each other, or acceptable range. I have to be very careful when what I say. Okay, so you can kind of see the Zimmer implant, Astra on top of the uni abutment, and an Astra on top of angle correcting abutments. Okay, so here you can see there was about 11 millimeter space, and then here you can kind of see that there's only 3 millimeter or 2 or 3 millimeter space after you assemble angle correcting abutments, and on top of that you put the gold abutment and put a screw on, right? So from the implant platform, 11 millimeter becomes 3 millimeter to this level. Okay, so you lose 8 millimeter. So that tells you how much additional space or vertical room you need to develop proper contour with angle corrected abutments, right? So sometimes when we talk to our surgical collaborators, they're like, oh yeah, so what? You just use angle corrected abutments, and then I have to ask, do you know how much space we need? How much additional space we need to use the angle corrected abutment? Yeah, a lot of times the surgeons they don't know. Okay, so that's our job to communicate with the surgeon and tell them that, like, if there's no bone, if you cannot control the orientation, then place deeper, right, as deep as possible. And as a restorative dentist, we always fight for space. All right, but there are cases that we can't do anything, right? So this particular implant was removed because we cannot restore this tooth? Well, I've seen some like a chair-shaped restoration on top of implant online, but we didn't want to restore this one. We didn't want to take any risk. And then plus, this patient might not need any implant here and might not need a tooth here, right? We don't need 32 teeth to survive. Okay. So that's why we always want to go back to drawing board, design implants properly from the beginning, right? Because we don't want to deal with all these like too deep, too shallow, and a like angled abutments, implants, right? So that's why we do always take a CT scan and then come up with a proper surgical guide and make sure the depth and angulations and position of the implants are optimal. Okay, so this is the example of the surgical guide on top of the patient had a bridge before, but we wanted to make it change to single crown, and the implant crown, because the study showed that the fixed partial dentures worked really good for first 10-12 years, and then from that point you get secondary caries and stuff, especially with the elder generations. So here we can kind of see the implants were placed fairly good and following the surgical guide, right? You can kind of see the screw channel is right coming from the hole that you made. But this is almost like a conventional surgical guide. This is not even the like fully guided surgery. So if your surgeon is good enough, like, sometimes they can even eyeball it. But as long as your guide gives the definitive contour at the cervical, and then you tell the surgeon that from this point go down 3 millimeter, or 3.4 millimeter, 3.5 millimeter, or even 2.5, depending on the implant company the implant system that you're using. Okay, so measure all the parts out, and then so that you know how much space you're gonna need, depending on you're restoring molar, are you restoring the premolar, or you're restoring the anterior. Okay, so each tooth, because of this the size difference, and then because of the shape, like mesiodistally and faciolingally. So with the same diameter of implants, you might require different depth control, okay, to achieve better emergence profile without compromising the stability between bone and soft tissue and implant. Okay, so all these factors you need to take into consideration. All right, so do we have enough time to do full mouth? Yes. Okay, so when we deal with the full mouth reconstruction, okay, we all understand that all the changes that the patient go through with losing all the teeth, right? We're a lot easier if we can obtain pre-extraction record. Because we believe the original teeth were supposed to be in the right position and right size and function correct way, right? But a lot of times it's not the case, right? So what's the first thing that we do here, right? Why are teeth so important? So that's the real question. So throughout the art history, you can kind of see that like, the very, very ancient art form, no teeth are shown, right? So here, so even smile, no teeth. Even the greatest smile of the history, no teeth shown, right? So until 17th century, right? Like in the art format, you can kind of see teeth showing. So that was my like I was just like watching. Flip through all these art history and paintings and stuff, I found that from this era, people started paying attention to like details in the teeth form. So if you look at these two paintings, right? So you can kind of see supernumerical tooth right here, and then excessive gingival display on this painting. So I was amazed how detailed, how observant the painter was, the artist was. So that means that the people are paying more and more attention to the teeth. And then like nowadays, you can kind of see that like many people only for the aesthetics and cosmetics, right? So they do like 16 teeth veneers and just for look, right? So it's not a surprise for us to do a lot of aesthetic works now. Okay, so teeth are important, right? So now, what's next thing? Like where and how big teeth we want to place, right? So this is how we do the denture setup, right? So we do the wax rim trying, and the wax rim needs to be where the future teeth needs to be, okay? And then we replace the wax rim with the teeth, and that's how you do the complete denture, right? And then that's the complete denture, right? Okay, so, and then we need to understand that I said our cavity is our limit, and then the opening is the upper and lower lip, and then that's the window of the aesthetic window that we are developing. And then so we have to consider the lip form, lip shape, lip mobility, and then so basically we're fitting all these teeth right in this window. And then these are all very dynamic. And then different ratios have different nasal labia angle as well. So if you can look at the based on the gender and then based on ethnic background, you can kind of see the different angles. Okay, so do not use the one average to fit to all. Okay, and then we have learned about phonetics, the importance of the phonetics and the importance of the lip support. Right, so phonetics, we always start with the frictive sounds to make sure the maxillary anterior teeth working perfectly with the lower lip, and then after that we have to use the sibilant sounds to make sure the mandibular front teeth, mandibular anterior work perfectly with the maxillary anterior, and then that sets your anterior guidance based on that. Okay, so this is an example of the frictive sounds, right? And sometimes the lip support is very challenging subject to tackle because of the age difference. For a young patient, have a little thicker tissue, a little bit more fat in it. For the elder generations, naturally you lose the tension of the lip, so you always have to feel the tension of the patient's lip whenever you try in the wax rim, whenever you try the teeth, right? Based on the same age group. So you will have all different age group patients whenever they come in. Just feel the tension, even with the natural dentition. Feel the tension, and eventually you will develop the feel on your fingertips. So you can feel the tension of the patient lip. Okay, so that's a really good indication of the lip support as well. Not only the aesthetic appearance. Okay. Okay, so this was one example that like did the wax rim try-in and then change it to the teeth setup and then try it in patient mouth, and everything was good. Okay, so the same principle here. You can kind of see the because of the severe loss in the maxillary anterior bone ridge, right? So it became almost like class 3, but patient was not class 3. So now you have to build up the teeth, build up this lost tissue, and then this is how much discrepancy you can see. Okay, and based on the CT scan, you develop the surgical guide, right? And then because of the the patient showed up after the bone grafting failures for 2 times, and that's why we didn't want to do another bone grafting, right? So instead we just use whatever remaining, and then place the 3 implants, and then using another implant right here, and then connect them together to develop the final prosthesis. Okay, so this is where it starts. Okay, and then whenever we talk about all these like wax trim and stuff, we always talk about where the original teeth has been, and then where we want to place the teeth. Like, and the neutral zone is the concept that you always want to think about to find out where the no stress zone here, and then that's the place that you want to put your teeth on. Okay, so there are a couple of articles talking about using the neutral zone to find out the teeth position, and then even like recontouring the complete denture. Okay, so after teeth positions are found, right, then now we have to divide that into upper and lower, right? And then at the front, you can kind of see that it was divided by incisal edges. But what about the posterior, right? So a lot of like when in dental school, we always talk about regimental pad and stuff. But if you really think about the function, right, the patient tongue movement is really important. So the patient tongue level determines or dictates the occlusal plane height and orientation. Okay, so you always have to evaluate patient tongue in dynamic motion. Right. So this is one example of just using the couple of implants supported record base or platform, and then using the bite restoration material to make impression of the tongue when patient swallows. And then at the same time, this gives you a really good idea about the neutral zone. So combining neutral zone concept and tongue dynamic concepts, right? So you put together those 2 concepts and then develop, see the tongue impression of the like bite restoration, and then that will give you clear idea where the teeth are supposed to be. Okay, and then restore from there. And remember, not everybody's occlusal plane is perfectly parallel to the interpreter line. Okay, so this is not patient. So Brian, you can never provide occlusal plane that is parallel to his interpreter line. Okay, so every patient is different, and you treat them differently. Any questions so far? And I think we're at the 9:54 now, and I'll stop right here, and I'll take any questions from now.
All right. I mean, this is very, I mean, thank you so much for all the details that go into, it looked like a simple case, but, if you don't attend to the details well, you are going to get into something that is not, looks so nice. I mean, I like the single, they're quite challenging, single cases in the aesthetic zone. They are quite challenging. So what did you say will be like an adequate depth of the implant in terms of the, between, what's the adequate depth between the implant platform and where it comes out, in emergence profile?
Like, so far, universally, like everybody talks about 3 millimeter, but depending on as I said, depending on the implant system that you use, like for Straumann bone level implant, you want to place a little deeper, like maybe 1 more millimeter deeper.
Okay.
For Astra, same thing. But Zimmer, 3i, Nobel, you can stick with the 3 millimeters for now.
Okay.
Depending on the diameter as well. Like if you have a lot of bone, and then you can use like very, very big, like 6 millimeter diameter, then you can place a little bit shallower. Like you don't have to get like 3 millimeters. And of course, it's also depending on the the tissue thickness as well, like and the tissue biotype or phenotype, right? The thick tissue it is very stable, and then we can just stick with the crystal bone, and it depends on the crystal bone, the bone crest level as well. So there's so many things that you wanna really consider. So diagnostic wax up is extremely important. I can't say.
Yes.
How important is that? And then from that dots, you kind of like plan with a CT scan, and then that will give you a really good result predictably every single time.
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator